Thank you, madam. Since we are running short of time, I'll just very briefly give an overview about how to manage angle suspects, or rather how to deal with angle suspects. Angle suspects per se is a very broad term. It can be an open angle suspect or a closed angle suspect, but we'll be focusing primarily on primary angle closure suspects. Gonoscopy, as we all know, is very, very important, and a proper gonoscopy can give you a very important insight into the etiology of disease also. If I'll just share this slide, you can see there are 4 patients with different types of synechia. This is the first patient on the top left. You can see these point synechia. Very typically, we see in patients with primary angle closure glaucoma. On the right side, you can see these large tent-like synechia, often seen in patients with uveitic glaucoma. Lower left side, you have a broad synechia with the rest of the angle open, often seen in eye syndrome. On the lower right side, you have large iris strands extending well beyond the Solvi's line with multiple holes in the iris. These are basically seen in X and Fields wrinkle anomaly. So gonoscopy can give you a lot of insight, not only about the open or close angle, but also in the etiology of the disease. Now, why we were focusing on angle closure? We all know that in India, we have more angle closure glaucoma, but what is more important that it is a preventable cause of blindness. If you do a gonoscopy timely, you do a PI, most of the patient will never progress to angle closure disease. There have been multiple classifications. The most common, as you all know, the ISGEO classification of primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. So suspects are patient where more than 180 degree, you can't see the posterior trabecular meshwork, rest everything is normal. But when this is associated with other finding like raised IOP or synechia, iris atrophy with no disc and field changes, then these are primary angle closure. And when you have additional disc and field changes also, then we call it as a glaucoma. It is important to classify patients in these groups because unless you do that, you won't be able to manage them correctly because the approach is different in all the 3. It is very important to learn indentation gonoscopy because here you can differentiate an apposition from a synechal closure. And as we have discussed, presence and absence of synechia is extremely important for classifying your patients. Treatment of PAC or PACG is more straightforward. Iridotomy is needed for all patients, even if you have extensive synechia. Medical management is similar to primary opening glaucoma, except in plateau iris syndrome, where we will be considering and using pilocarpine. And definitely, we have a lower threshold for cataract extraction. But in case of PACS, whom to do iridotomy, it is still not very clear. In fact, the preferred practice pattern by American Academy has highlighted that there are no completed trial to clearly classify or document the role of iridotomy in PACS. The Valora study have shown that if you don't do iridotomy, only 22% patients with PACS progress to PAC, and none of them actually developed glaucoma. And the more recent ZAP trial also has shown that over a 72 months period, which is 6-year period, even if you're not doing PI in a patient with PACS, only 7.9 out of 1,000 patients actually progress to PAC. So to prevent one progression, you need to treat 44 patients, which is a very high number needed to treat. So to highlight, definitely not all primary angle closure suspects need iridotomy, but in case the patient has got other acute angle closure attack, you definitely should do iridotomy. Or else if the follow-up is an issue, needs regular dilatation, patient has got some sign symptom of angle closure or a very strong family history, you should be doing an iridotomy. In other patients, just keep them under follow-up, document your finding, and in future, if you see these patchy pigmentation indicating an iridotrabecular contact or the patient start developing these early synechia, definitely you can go for a iridotomy. So to conclude, suspicious angle, you should have a comprehensive evaluation. Always remember you are treating the patient and not the angle. Thank you so much.